Learning Plan 5, the cardiovascular and renal system medications. Cardiovascular, we're going to cover heart, kidneys, lipids. Hyperlipidemia is a problem. It leads to atherosclerosis, and we want to prevent that. It's so much easier to prevent than it is to treat. What are some risk factors for hyperlipidemia? Being a male, 45 or older, or woman, 55 or older, or women with premature menopause. Family history of cardiac heart disease, smokers, people with high blood pressure, people that already have bad lipid problems, people who are obese or have diabetes. Those are all risk factors of hyperlipidemia. Target damage. The hyperlipidemia affects the heart, the brain. It causes chronic kidney disease, peripheral artery disease, and retinopathy. 3 ways of treating it. Lifestyle change. 2 ways of treating it. Lifestyle changes, weight loss, aerobic exercise, and dietary changes, and medications. So what are we looking at for medications? We have 5 kinds of medications. We have the HMG-CoA reductase inhibitors, also known as statins. We also have bile acid sequestrants, nicotinic acid or niacin, fibric acid, and cholesterol absorption inhibitor. These medications work in one of 2 places, either within the liver or in the gut. If they're in the liver, it's preventing the release and creation of cholesterol. If it works in the gut, it's preventing the absorption of cholesterol. Statins, it works best if you take statins always in the evening. It works in the liver to prevent the production, because our liver makes cholesterol in addition to what we eat. We should always try to change our diet first, but if that doesn't work, then we have to look at medications. So statins are always the first choice. Bile acid sequestrants. These are things that sequester cholesterol in the gut so that we eliminate them without absorbing them. These work in the gut. This would be like Questran or cholestyramine. This decreases the LDL by 15 to 30%. Fibrates work in the liver. We're looking at things like gemfibrozil or fenofibrate. These are in the liver, and it decreases hepatic production of cholesterol. Niacin works in the gut. Again, we're kind of going back and forth if you noticed. Niacin is a B vitamin. It's the same B vitamin you can buy when you go to the store and buy a B vitamin. But it's much higher doses. Now, this works very well for increasing the HDL and decreasing LDL and decreasing triglycerides. So that's excellent. You want high HDL, you want low LDL, you want low triglycerides. Unfortunately, and all medications have side effects, this one causes really bad flushing. And a lot of times people will just stop taking it because it's just like a whole body flush, and it's very uncomfortable. If you are one of the people that have a flush, if you take an aspirin beforehand, that'll usually prevent that flushing. The last medication also works in the gut. These are the cholesterol absorption inhibitors. It says it right in the name. It's a cholesterol absorption inhibitor. Things like ezetimibe. And these also work for decreasing triglycerides, LDL, and increasing HDL. Now let's look at hypertension, a major disease. There's 2 types of hypertension, idiopathic and secondary. Secondary first. Secondary is hypertension because it's caused by something. Idiopathic, it's just there. Nothing is causing it, you just have high blood pressure. Our goal is to keep people under a systolic of 120, under a diastolic of 80. As you break those barriers, you go into pre-hypertension, hypertension stage 1 and stage 2. There's a lot of things that can cause hypertension, and we can control only a few of them. We cannot control our genes. We can't control our race or gender. We can't control our age. We can control our activity level, our stress, obesity, our tobacco use, salt, and alcohol. So we can only control what we can, but those things really should be controlled. We can treat high blood pressure with, or hypertension, HTN, with 6 medications: diuretics, calcium channel blockers, ACE inhibitors, angiotensin receptor blockers, adrenergic agents, and direct vasodilators. So let's talk about what these are all like very briefly. Diuretics treat blood pressure by reducing the blood volume. They increase urination, so they pull fluid out of the system. Remember, blood pressure is caused by 3 things: how hard the heart is pumping, how fast it's pumping, and how much fluid is in the system. If you look at it, a set of pipes and a pump, we have a pump, we have pipes, we have water. If the pump is beating hard or beating fast, the pressure goes up. If the pipes are smaller, the pressure within the pipe goes up. And if we try putting more fluid in the system, the pressure goes up. So how we treat blood pressure, we can treat blood pressure by changing any one or all 3 of those. Slowing the heart, reducing the pressure on the heart, removing fluid out of the system, or making the pipes wider. Diuretics reduce blood volume. We have 3 types of diuretics: loop diuretics, thiazide, and potassium-sparing diuretics. Loop and thiazide, the key lab you have to remember at all times is what's the potassium level, because loop and thiazide you will dump potassium. Potassium-sparing, you also have to know the potassium level, because potassium-sparing diuretics do not dump potassium. So you have the chance of becoming hyperkalemic or high potassium. With loop and thiazide, hypokalemia, low potassium. Thiazide diuretics are very simple. They're not as effective as loop diuretics, but they do work. The most common is hydrochlorothiazide, and very commonly you'll see that tied in with another medication. It's a combination medication. Make sure that the person understands that they may need to increase potassium in their diet. So sources of potassium: bananas, the most common, melons, citrus fruits, potatoes, particularly the skins. These are all help bring potassium in. Loop diuretics are much more powerful. The same teaching though. Make sure that they're getting enough potassium in their diet, and so teach them to monitor that. Potassium-sparing diuretics, you may want to eliminate some of those foods because your body will start holding on to that potassium. Now, calcium channel blockers do 2 things. It slows the heart, and so in slowing the heart, it prevents the heart from pumping quite as hard. It also reduces peripheral resistance, meaning it makes the blood vessels a little bit bigger. Bigger pipes, water and blood flow through easier. So calcium channel blocker affects 2 parts of it. Slows the heart and makes the blood vessels larger. Calcium channel blockers have a major side effect of hypotension. Sometimes they can go too far and make the person have low blood pressure. They'll get dizzy, lightheaded, nauseated. They risk for falling. It can also cause Stevens-Johnson syndrome and peripheral edema. That's something. Think about that. We want to get fluid out of the system, but with calcium channel blockers, it actually allows fluid to leave the system but enter the tissues, and you'll see dependent edema, ankles, calves, legs a lot. ACE inhibitors affect the blood volume and the diameter of the vessels. So an ACE inhibitor, or a prill, remember prills, will be used to increase the blood vessel size and eliminate some urine out of this, some blood volume out. A risk of this is you want to use these very careful if the person already has high potassium levels or hyperkalemia. Also, a person may develop a dry cough, and I once was on ACE inhibitors, and I developed the cough. It's very dry, hacking, and it's very annoying. It will almost always cause people to stop taking it. It also can cause postural hypertension. Standing up quickly causes the blood pressure to drop suddenly. So make sure, patient teaching, get up slowly. Watch out for angioedema. This is commonly used for not only blood pressure but heart failure. Angiotensin receptor 2 blockers, ARBs. Very similar to the ACE inhibitors without the same side effects. It does increase more sodium excretion, arterial dilation. Not many side effects, but they're very expensive. We have adrenergic drugs. We have alpha-2 agonists, alpha-1 blockers, and combined alpha-1 and alpha-2 blockers. So the alpha-adrenergic agonist, this is commonly used for blood pressure, but even more importantly for BPH, benign prostatic hypertrophy. Commonly will cause dizziness and headaches. The beta blockers are used for, has the side effects of, lost my page there. It can cause fatigue and dizziness. A beta blocker will slow the heart rate down, decreasing blood pressure, but it very frequently will cause fatigue and weakness. It also causes impotence, like I mentioned before. These are side effects that will frequently cause people to stop taking it. If you take a medication and you're getting tired all the time, are you really going to want to take it? Or impotence? Now, another category of medications are the direct vasodilators. These drugs do nothing but make the blood vessels get big. And there's nitroprusside and hydralazine are very common. Nitroprusside is for life-threatening hypertension. This is given only in like an ICU or critical care setting. Hydralazine is for moderate to severe hypertension. Like beta blockers, dizziness and headache are very common here. It can cause tachycardia. When the blood vessels get so big, sometimes the heart starts beating faster to compensate. These can cause sodium retention. Now, heart failure is a different condition. Heart failure is caused by the heart is unable to pump blood out, so blood starts backing up. If the left side of the part of the heart that pumps blood to the body starts backing up, blood moves into the lungs, causing fluid in the lungs, crackles. If the right side of the heart is inefficiently beating, fluid backs up into the body, most commonly in the lower extremities, so you're going to develop peripheral edema. Shortness of breath is common. Increased respiratory rate, orthopnea or leaning forward to breathe, extra heart sounds, fatigue, weight gain. Those are all signs of heart failure. What do we use for heart failure? Some of the same drugs we just talked about. We want to get fluid out of the system, so that's a diuretic. We want to change how the heart beats, so we might be giving ACE inhibitors or ARBs. We might be giving beta blockers to slow the heart down. We might give cardiac glycosides like a digoxin to slow the heartbeat, but make it beat harder. Cardiac glycosides or digoxin, commonly given in the morning. You want to watch out for some side effects that are rather unique to this medication. One of the side effects is blurred vision or seeing like a yellow-green halo around things. That indicates toxicity. This causes anorexia or lack of appetite. Nausea and vomiting is very common. Bradycardia or heartbeat under 60 beats a minute. You will always check the heart rate for a full minute. If it's under 60, you will not give your digoxin. You'll monitor lab values, specifically the digoxin level, or we call it dig level, as well as potassium levels. If we're giving this with diuretics, which is not uncommon, we need to be very careful. Hypokalemia and hypercalcemia will interact badly with this. So loop and thiazide diuretics can cause problems. ACE inhibitors can be used for heart failure with the same side effects, that dry cough, as well as beta blockers, again, to slow the heart down, to help the heart beat smoother, maybe allow more blood to flow out as it beats. Angina, or is chest pain or heart pain. Angina can lead to myocardial infarction or heart attack. We use 3 types of medications to treat that. Nitrates, beta-adrenergic blockers, and calcium channel blockers. Nitrates, or nitroglycerin, has a massive vasodilating effect. It will almost always cause a headache. This headache may be treated by medication like an ibuprofen or a Tylenol, but probably not. But we need that vasodilation so that the resistance to the blood is reduced and blood can flow to the heart and brain better. What will you teach the person if they're taking nitroglycerin? Watch out for postural hypotension. Get up slowly. Where will you put it? Generally under the tongue, sublingual. And it absorbs directly into the skin. You do not have to swallow this. The patient will feel tingling under their tongue. And again, that headache will come on very quickly. This decreases myocardial oxygen demand. Because the blood vessels get larger, the heart doesn't need as much oxygen, which is how the angina is relieved. Beta blockers are used. These are negative inotropic. They slow the heart. So if they slow the heart, you again are at risk for dizziness, lightheadedness, bronchoconstriction, as in an asthma attack. Calcium channel blockers, again, are used for chest pain. We want to watch carefully for hypotension and peripheral edema. Peripheral edema using calcium channel blockers can actually trigger congestive heart failure. So we have to use this very carefully. We'll always be monitoring the patient's weight. Preferably weigh every day. If you see a rapid weight gain, you need to notify the doctor. Now let's talk about medications that affect clotting. We have 3 types of medications. We have anticoagulants, antiplatelets, and thrombolytics. Aspirin is an antiplatelet. It decreases platelet aggregation. Now we're looking at low dose, 81 milligrams, 162 milligrams, maybe 325 milligram. This is not for pain or fever. This is for platelet, to prevent platelet aggregation. It can cause tinnitus and hearing loss, so we have to use this carefully. It's good for myocardial infarctions and TIAs, or transient ischemic attacks. We can look at direct platelet inhibitors, like a Ticlet or a Plavix. These also work on platelets, and they prevent the platelets from clumping up. Now, we also have thrombolytics. Thrombolytics don't prevent the clot from forming. Thrombolytics break up and dissolve the clot. Thrombo is the clot, lytics, breaker. So these dissolve clots, commonly called clot busters. You can only use these under very specific circumstances, though. If the person has a suspected brain bleed or recent surgery, you cannot use the thrombolytic because it will not only open the clot in the brain or the heart, but it'll open clots everywhere. So if the person was recently in a car accident, probably will not get a thrombolytic. We also have anticoagulants. There's 3 of them: heparin, enoxaparin, and warfarin. These all work on various parts of the clotting chain. You don't need to worry about that so much as just remembering that these all they have the same end result but work differently. Heparin is very rapid acting. It's usually given IV. It can be given sub-Q. It's monitored by the lab's PTT, or APTT. It could be referred to either way. But a PTT is how you measure if they are in a therapeutic level. If they're subtherapeutic, they'll increase the dose. If they're super therapeutic, meaning too high, they will lower the dose. If they have far too high, they'll reverse it using protamine sulfate. Protamine sulfate actually reverses the effects of heparin. Lovenox is similar to heparin. It's a low molecular weight heparin. There are no direct labs. It's given sub-Q only. And there's also no direct reversal agent. So heparin, protamine sulfate reverses it. PTT, you can check for lab values. Lovenox, or enoxaparin, Lovenox is a brand name. Enoxaparin, no labs, no reversal agent, sub-Q only. People will go home with Lovenox. People will never go home with IV heparin, or I've never heard of it. Warfarin is PO only. It's a tablet. You monitor it by checking ProTime and the INR. PT/INR is how you monitor warfarin levels. If they're too high, or if the person suddenly needs surgery, it can be reversed by vitamin K. Not K+. K+ is potassium. Vitamin K is actually a vitamin that's used in the clotting chain. That is it for that's it for this rapid review of the cardiac and renal drugs.